Okay, off we go again, guys. So, like the majority of our conversations that we've had, we've taken maybe like a 15,000 foot view of these conditions, meaning we're up pretty high in the air and we're just kind of trying to get a generic outline. Okay, so for GUN, GYN, we're taking maybe a 30,000 foot view. Okay, so really just trying to give you a generic idea of what's going on. Okay. So one of the very first things that we need to agree upon and be aware of is, it's important that we use appropriate anatomical names, okay? And that's what you'll hear me use throughout this time. At first, when you start doing that, it probably feels a little awkward because growing up, often those were kind of taboo words, but trust me, your patients are a lot more awkward and nervous when you're examining these parts of them, and it increases their trust in you and their comfort when you use appropriate terminology. Okay, so now's your time. Take a deep breath, get over it. It will be okay. Okay, so basic anatomy and physiology. Right now we're talking about, like, for the kidneys. The kidneys lie posteriorly to the peritoneum, and they're in that retroperitoneal space on the posterior abdominal wall. Okay, and they're right alongside the spine and against the major muscle groups right there. Okay. The role of the kidneys in the body is to remove excess water, salts, and products of metabolism from the blood. And then the waste products are conveyed out in the urine. And you hear a lot nowadays about, a 24-day cleanse or a 24-hour cleanse, or drink nothing but cucumber onion water or whatever for 24 hours. And it's like, if you have a kidney and you have a liver, that's the best cleanse you can get. Okay, so don't waste your money. Okay, this is what anatomically the kidneys look like. Not like it's, super crazy critical that you remember all these major structures, but if you have a general idea of what the anatomy looks like, that's always important when you start thinking through pathophysiology. Okay. Okay, and then here's the bladder. Okay, so you'll see there's a lot of musculature around the entire bladder wall. And lining the inside of the bladder is transitional epithelium, which starts off pretty tightly linked, and as the bladder fills, it can stretch out, and so that's how, that feeling of stretching is when people feel like they need to void. So just keep that in mind, and also be nice to your female friends. The women's bladder is like maybe 2/3 the size of the man's bladder, so when she has to stop all the time on road trips, be nice. Okay, male anatomy, once again, important to understand what's going on here. So let's take a look here. Oh, let me get my pen again. Okay, so I'm just going to highlight some things for later on. So for the prostate gland, that's right here. Okay, so you see how this is the bladder and this is the urethra, and so do you see how that the urine has to cross through the prostate gland to get out? And if this gets too big, then it can pinch off that urethra as well. Okay, and so then the vas deferens connects here. This is the testicle, and then it comes all the way up here. Okay, and then we're not going to go into great detail or really any detail about semen or sperm, but all of these structures here play a role in that. Okay. So the epididymis is this structure right here that can sometimes you can get an epididymitis as well. Okay, so that can be an area of inflammation. And then also when we talk about UTIs, think about how long this urethra is, okay? As opposed to like a woman's urethra is only like that long. Okay, so that's part of why men aren't as susceptible to UTIs as women, because that bacteria has a long freaking way to travel until it gets up into that urine. And then men start to have UTIs more often later in life when this prostate gets enlarged, and then they have urinary retention up in here, okay? So when they're not able to get a good squeeze and all that urine goes out, it's able to just sit there and kind of fester and grow weird, nasty stuff. Okay, so this is a picture of the testy and the epididymis itself. And you see all these like little coil thingies. Okay, that's where sperm is actually made. Okay, and so then it hangs down here, and then you have the spermatic cord and the blood supply. Okay, so now this is the female anatomy. Like I said, here's the length of that urethra, not very long at all, right, in comparison, and so it's a lot easier for bacteria to get up in there and cause and wreak havoc. Okay, and then also, and so then here's the vagina, and when you're looking through this, it's called the vaginal vault. Okay, and then up into the uterus. Okay, here, and so then when looking at this picture, it makes a lot more sense, you know, when a woman is pregnant, that uterus grows probably up at least to like that. And so then it's pushing on everything else that's in there. Okay. Let's see, what else do I want to highlight here? I think that's about it. Okay, and so then this is the uterus again. These are their ovaries. The ovary is not actually directly connected to the fallopian tube. Okay, so when an egg develops, it develops here on either the left or right side, travels down here. Most fertilization with sperm happens somewhere in here, and then hopefully it were to come down here and actually implant. Okay, and so then the uterus kind of narrows out down here to the cervix, and the cervix and the cervical os is this opening right here, and then into the vaginal vault. Okay, so really not going to go into this in great detail. Menstrual cycles, we're kind of back from here on out a little bit in, you know, high school health class, so bear with me. But these are important things to know, not just for your life as an athletic trainer, but just your life in general. Okay, so average is about 28 days, proliferative or follicular phase, and then the secretory or luteal phase. So proliferative before, how it is that egg develops, and then it opens, and there's like the smaller part inside of it, and so while it's developing, it's proliferative. Afterwards, it's luteal, and different hormones are more prevalent in different parts of those cycles. The endometrium is that innermost layer of the uterus, and it builds up a blood supply for implantation. If fertilization and implantation don't happen, then that buildup, that lining gets shed. And this is a big question a lot of times for women that are on birth controls that cause them to not have a period. People get really anxious about that, like why do I not have to bleed every month? And it's really because this endometrium isn't growing at all. So if the endometrium doesn't grow, it doesn't need to shed. I think of it like you're like mowing a lawn. Okay, if the grass doesn't grow, you don't have to mow it. Okay, so there's nothing wrong. It's not like something's permanently changed. It's just that endometrium isn't building up anymore. And then physiologic changes of pregnancy, little side note here, and I think I've mentioned this in a previous lecture. Women of childbearing age are pregnant until proven otherwise, okay? And I don't know how many times that was like beaten into my brain going into this, but for you guys too, okay? I know it's a little bit stickier and a little bit more complicated because, you know, these women are competing in, you know, pretty high intense exercise, but look at Serena Williams, like did she compete or did she win? I don't know, but in a major Grand Slam while she was pregnant. So I mean, obviously still some pretty awesome things can happen, but even if people say they're taking birth control, like, sometimes there's problems with, actual timing versus all sorts of different things. So a woman is pregnant until proven otherwise. So you need to take precautions when you treat them as if they were pregnant, okay? Because the litigation and the risk if you were to mess up a possible fetus or even cause a miscarriage is like nuts, okay? So always remember that one. Okay, so some of those physiologic changes, cardiac output increases because of both stroke volume and heart rate. And if you think about it, that uterus is getting really big and it has that placenta, that it also has to have blood flow and all these other things. Plasma volume increases, okay, to help with that as well. And so because of that, now all of a sudden this heart that's always been the same size has like tons and tons of volume in it, so much blood. So all of that blood moving through those valves can actually cause a heart murmur. And most of the time it's totally benign. It's just a result of all that extra volume. And then the blood pressure itself decreases, which seems weird because you're like, well, what about all this extra volume? And it decreases because it decreases in systemic vascular resistance. So remember when we talked about the arteries, and they are wrapped around with those smooth muscles, and those smooth muscles either contract or relax in order to create the changes in blood pressure. So those smooth muscles relax, okay, which causes the blood vessels to get bigger, and that systemic resistance is less. And in general, just kind of everything in a woman's body relaxes, like her hips, her pelvis, all sorts of, in order to help open up the room for baby to go down the birth canal. But you can get a lot of problems with like joint instability and such, because like all their ligaments are just like just hanging out, get really loose. Your book mentioned an increase in tidal volume, and tidal volume is, the amount of air you move every time you breathe. And I'm like, yeah, maybe at the beginning of pregnancy, but then like towards the end, when it feels like your uterus is up at your clavicle, like you're not moving a lot of air, so your respiratory rate increases. The core temp also goes up as well. Okay, so evaluation of GU and GYN systems. Okay, it's so important. Like I said before, maintain a clear and professional demeanor using correct medical and anatomical terms. And honestly, guys, you got to be smart about it. We live in the Me Too age movement, and I'm not, please don't misunderstand me, I'm not diminishing real experiences by both men and women. But what I'm saying is you need to be careful. If you're going to examine genitalia or really anything that could even get close to there, you need to have a chaperone. And what that means is another person, like highest benefit if they're the same sex as the patient, okay? And just document the heck out of it and who that person was to help protect yourself, because there are, like I said, the Me Too movement is very, very real, but then there's also, you don't want there to be any room for anybody to say anything, okay? And then also it's important that the questions that you ask are pertinent, okay? It's not just because I want to know, I'm curious. You're asking pertinent questions about signs, symptoms, and onset, because people have also gotten into a lot of trouble for that, because it was thought that they were just, trying to find out information about, whoever's sex life or whatever. The goal of these evaluations is to collect just enough to know who to send them to, okay? To make sure that, like we've talked about in the past, that this isn't, an emergency. This has time to wait, and which provider is the best to go to. And then once again, confidentiality, okay? So this is really awkward for people to tell you, okay? Especially like probably for you guys, because you're their peers, okay? Like they're the same age as you. Or even if there is a big age gap, like an older person speaking to a younger person and vice versa, it's so important that you have these conversations without judgment, okay? And that you keep it to yourself. Like, people will tell you things from, it hurts when I have sex, or I've had, 10 sexual partners in the last month, or whatever it is, but that's really personal information, and this is, one of the times of many that it's absolutely paramount that patient has some privacy to tell you that in, which I know in your guys' situation is hard, but some privacy, and to keep that confidential, because because that's obviously not anything you would personally want kind of spread around. So kidney stones, when you're looking for kidney stones, oftentimes people complain of back pain that then wraps around to the front of their stomach. And this is a great example of how it's important to find out how somebody's symptoms have changed, okay? So if your person just comes in with stomach pain, like we talked about last time, abdominal pain can be horrendous to diagnose because there's just so many options. But kidney stones, it starts out as back pain, and then as the stone moves through the ureter, if you remember back to that anatomy picture, it wraps around to the front, and then the pain increases. Okay, so they're also called renal or urinary calculi, which, because like I said, that's the $40 word for that. It happens when the urine becomes supersaturated with a salt. There's multiple different kinds that's capable of forming solid crystals. These can be found in the ureters, the bladder, or the urethra. And most of them pass on their own, okay? But it all depends on what size they are. It is possible for them to get like lodged in the ureters, and so then people can't pass it on their own, and that's an emergency. And sometimes people are even hospitalized just because of how much it hurts, or dehydration, or like I said, the inability to pass it. Sports hematuria, so you would find this out either because it's a gross hematuria, and remember in medicine, gross, when I'm saying gross, it's not like yucky, it's like large, okay, as opposed to micro. So gross hematuria, either that they can, typically that they can just, see when they void, or if you see it on dipstick, is typically benign, self-limiting, and it's associated with, really intense activity. Okay, and if the hematuria is because of their intense activity, it resolves in about 72 hours. Okay, so UTI, or urinary tract infection, okay, can occur in either the upper urinary tract, like in the kidney, or in the bladder and the urethra. Okay, so let's get a couple of terminologies straight. So I can only call it a urinary tract infection if I have obtained a culture and can grow it out and say, this is the bug that's doing it. Okay, that's like officially a UTI. We use UTI for kind of like slang for kind of everything, but like an official definition, that's what it is. Okay, versus cystitis is just like, is kind of the catch-all when I'm like, this is a UTI, but I can't officially say that. So that, like, I'm having dysuria, which is pain with voiding, or frequency or urgency, or I'm just like, I'm pretty sure this is, but I can't confirm it yet. Okay, versus pyelonephritis is when that infection has climbed up into the kidneys. Okay, sexually active young women are at the highest risk. Okay, do you remember why that was? Think back to your anatomy. Okay, we mentioned this, that urethra is really short. It doesn't take a lot. And then any type of sexual activity, like regardless of STIs or whatever, it kind of stirs up and loosens up bacteria and kind of creates a storm for things to move, okay? And then it's really easy for it to jump on board that urethra and climb up into the bladder. Symptoms include dysuria, frequency, urgency, foul-smelling urine or odor. And then, so say you had like an 18-year-old man come in and complain of these same symptoms. We already talked about that UTIs in young men are not very common because of that long urethra. So honestly, most of the time when men come in and complain of these symptoms, they actually have an STI. So it's important to think of both things. So sexually transmitted infections used to be sexually transmitted diseases, but terminology was changed because we thought it would increase people's willingness to be tested, because an infection is curable versus a disease. There's a lot more stigma associated with it. Important to remember that they affect men and women differently. Okay, as we just saw, like anatomy is different, so obviously it would present differently, and oftentimes they can be asymptomatic. And just to dispel some things, no, you cannot get an STI from a toilet seat. Okay, sorry, but no. Okay. Signs and symptoms, like I said, can vary quite a bit from like either weird vaginal discharge or weird penile discharge, urge to void, but like you actually try to urinate and nothing really comes out, dysuria, that pain with urination, itching, burning, you could have lumps or bumps. I'm not going to go through a zillion pictures with you because, like I said, this is kind of like high school health class for this section, but I'm not here trying to scare you. Commonly sexually transmitted infections, HPV and genital warts, okay? And really, HPV is the only cancer we can vaccinate against, okay? And so since the Gardasil vaccines have come out, the rate of both cervical cancer and genital warts has plummeted. But unfortunately, a lot of young teens don't get it because their parents feel like it's like encouraging them to have sex or something. Like it does best, that vaccine works the best if it's given before sexual contact, but you can even give it like much later in life, into people's 20s, 30s, that kind of thing. Okay. Syphilis, gonorrhea, chlamydia, HIV, herpes type 2. So herpes type 1, like traditionally, okay, herpes type 1 or herpes lesions, like cold sores that you would get on your mouth. But because of like oral sex and such, you can have herpes type 1 genitally and herpes type 2 around the mouth. Okay, so just because of its location doesn't necessarily mean which type it is, and not like it really matters either way, but you can have it typed out to know. And there are antivirals we can give in order to help stop transmission. Okay, so this is what it would look like if somebody had, like, you know, that infected fallopian tube. Obviously that looks pretty painful. It's a lot bigger than it should be, okay? And even the ovary is inflamed. Okay, testicular torsion occurs when there's like a venous occlusion. And typically it's when, you know, the testicle is free to just like kind of like move around, okay? And so what happens is it has, if you remember back to the anatomy, it has that long spermatic cord, and it just lets it kind of wrap up on itself. And then that actual twisting cuts off the blood flow, okay? And the highest incidence is among, you know, those teenage males. Peak incidence is at 21, okay? More common in the left because it lies a little bit lower than the right testicle. Okay, so this is what that looks like. It just kind of turns in on itself here, cutting off that blood supply, okay? With that torsion, how do you know? Okay, so important for you guys because, like I said, 30,000 foot view, really testicular pain, and like unrelenting testicular pain, ship them off to the hospital right away, okay? Because you have to have an ultrasound to confirm this, and the risk is that if we don't find this out and fix it fast enough, that testy can die, okay? And something that we do in order to help, like, you know, differentiate between things is the Cremasteric Reflex. So what that means is if you were to like stroke the inner side of the thigh, the Cremasteric Reflex is that that muscle is going to contract and pull up the testicle on that same side, okay? And that's usually absent in torsion because you remember that those all of those muscle groups and the spermatic cord and such is twisted, so there's not a lot of room for it to move, okay? Hydrocele is a fluid collection in the scrotum, okay? Most of them are developmental in origin because there wasn't a closing of some of the holes in development. Oftentimes asymptomatic, can occur in up to 6% of adult males and can cause that like scrotal aching and painful scrotal swelling. So another thing to keep in mind is onset. Okay, so testicular torsion, pain's really fast. Pain with hydrocele is typically a lot more gradual. Like they typically won't really be able to tell you, oh, when it started. It'll be like, oh, I don't know, last week or a couple days ago, that kind of thing. Okay, and then this is what that looks like anatomically. Varicocele is a dilation of the venous plexus and internal spermatic vein in the scrotum, which is just a fancy way to say that the blood vessels and such in there are bigger. We don't know why. Occurs in up to 20%. Generally asymptomatic, but sometimes people say it's like an aching pain or a heaviness in the scrotum. And it's always described in the literature and in every class I've ever been in as like feeling like a bag of worms. And maybe I just don't go around holding worms enough, but I would have never called it that. I think it's just to say that like it's like heaviness and that there's like distinct big things that you can feel. But anyways, if that gives me a good mental picture, but when I've actually like, examined somebody with varicocele, I didn't necessarily feel that, but and this is what that looks like. Testicular cancer, okay, is abnormal growth of cells in the testicles, is 1 to 2% of all cancers in men and typically affects only a single testicle. It actually has a super high cure rate if diagnosed early, okay? And this is one of the few cancers that present earlier in life in men, okay? And it's important that men do monthly testicle exams, okay? And what does that mean? So they're supposed to like grasp the testy and roll it between their thumbs and their forefinger, kind of like this, okay? And what they're feeling for is any lumps, swelling, hardness, or just anything that feels different, okay? Prostate cancer, second leading cause of cancer death for men in US, but honestly, if you live long enough, you're going to get prostate cancer. It increases in incidence with age, and if you don't have prostate cancer itself, most men have, at least some level of prostate enlargement, which we had talked about a little bit earlier. Vaginitis, think about it, itis is inflammation, so inflammation of the vagina, usually caused by infection in the people that you would be dealing with. There are other causes, but for you guys, it's probably infection. Can be symptoms of, itching, pain, burning, weird discharge, that kind of stuff. And, sexually active athletes or even young women, not necessarily just an athlete. Candidiasis, that's yeast. Trichomoniasis, that's STD or STI. And bacterial vaginosis is just kind of when the normal bacteria that live down there just kind of go haywire. Okay. And also, this is one of those times that, you are asking a question in order to get important information, not just because you're sick and twisted, okay? So oftentimes I ask women, what type underwear do you wear? Because if they wear thongs often, essentially what happens is it gives a direct transport, like a highway, from the anus that has a lot of bacteria up to both the vagina and the urethra, okay? I don't know if I mentioned this previously, but you hear a lot about like, vaginal deodorants or douching or cleaning or all these other things. Like, they taught us to use the phrase that like the vagina is like a self-cleaning oven. Just leave it alone. It'll take care of itself. Like honestly, when you start adding other things into there, whether it's products or harsh soaps or whatever, you're just more likely to cause a vaginitis. And actually upset the pH and the normal flora that live down there and actually cause yourself more problems. Okay. Pelvic inflammatory disease is when any of those infections make its way up into the upper genital tract, like the uterus or the ovaries or the fallopian tubes. Okay. And then let me see. Oh, it's super, super crucial because it can lead to infertility. Okay, that's a big deal. So oftentimes it starts with STIs, and that's why, it's recommended that every individual, I think it's up to maybe 25, is screened for chlamydia once a year. Okay. Because chlamydia is super rampant and is often asymptomatic. And also, it's a super good idea for people to just, if they're having, you know, multiple partners, especially without protection, which is an entirely different conversation, but to just get screened periodically as well, or when they're starting a new relationship. Can also, like I said, can lead to infertility, increased risk of ectopic pregnancy, recurrent infections, or chronic pelvic pain. Dysmenorrhea, fancy way of saying, you know, painful periods. Primary is just like, you know, the normal cramping. Secondary is caused by a gross pathological process involving the uterus, often like a fibroid or uterine or ovarian cysts or something like that. Hot water bottles, heat packs, Midol can be helpful, those kinds of things. Oftentimes women get placed on birth control to help with this. One that wasn't in here is menorrhagia, fancy word for heavy periods, another good reason why people get on birth control as well. Amenorrhea, primary is absence of periods start by the age of 16, okay? So it's totally normal for a 15-year-old to not have had a period yet, okay? After age 16, then it's considered primary amenorrhea. And we see that a lot in gymnasts because of that high intensity training, and just stops their body's ability to mature into that time frame. And then secondary amenorrhea is like lack of a menstrual cycle after previously having one. And I guess I didn't look this up, but like pregnancy doesn't count. Like obviously you're not going to have a period when you're pregnant. But high intensity training or caloric restriction can cause secondary amenorrhea, as well as a whole host of other things. But ovarian and cervical cancer. Ovarian is is the leading cause of death from GYN malignancy. It's really, really tricksy in that, like, oftentimes people just complain of kind of vague bloating and abdominal pain. And we don't have a good, and it's not something that we routinely screen for too. So I would say if somebody has any type of symptom, like really for whatever it is, like there's all this stigma about like going to the doctor and being like, you know, a whiner, or, you know, you need to just suck it up and do it. But it's like, if something is hanging out and lasting that long, it's worth evaluating, okay? And even if we come to terms and be like, you know what, I don't know what it is, then that's fine, but we know what it's not, okay? And you only have to have a couple of people, like young women, like in their 30s, die of, you know, ovarian cancer to be like, you know what, I'll look. It's worth it to me to look. Like I said, cervical cancer has a really high cure rate if detected early, and with the HPV vaccines can actually even be prevented. Breast cancer, 10 to 15% originate in the ducts of the breast. And then another good chunk in the lobules. Breast cancer can metastasize pretty easily, first to the lymph nodes and then all over the body. Other than skin cancer, most common diagnosed cancer in women. Important for women to also do monthly breast exams. Okay, this is like a pattern, and I want to say that these are like the different options for a pattern when you're doing that breast exam at home. Okay. It doesn't really matter which one you do as long as you don't miss any tissue. Important to note that breast tissue goes like all the way up there and then up into the armpit as well, and then all the way down the sides. It's not just, you know, this rounded area, okay? And then a big part that women are looking for, they need to look in the mirror too, because there's like, if there's all of a sudden like a dimpling or like a retraction, then that could mean that the tissue is stuck to something underneath it. And you know, breast cancer can pop up in people in their 20s, okay? It's not just old people. Ectopic pregnancy, fertilized egg implants outside of the normal endometrial lining of uterus. It can implant in a lot of different places, but it's often in the fallopian tube. It's lethal for the fetus, okay? We can't like pick it up and put it in the uterus, okay? And it can be lethal for the mom. And we see this often in women who do like a positive home pregnancy test. They dip their urine, but then they don't go see their doctor. because they're either ashamed or concerned or afraid or whatever. Like, there's a whole host of different feelings that can go into it. But then the problem is that they don't get it verified on ultrasound. And that's one reason why we need ultrasound so early on in pregnancy, to make sure that it's implanted in the uterus, because otherwise that developing fetus gets bigger and bigger and bigger. And if you remember the size of those fallopian tubes, they're not very big. And it doesn't take much development for the fetus to grow so big that it actually ruptures the fallopian tube, and then we're in a whole world of hurt. This is what this looks like, okay? And possible sites of implantation can be kind of all over everywhere.